Good afternoon, everyone, and welcome to our Scholarship Across the Disciplines panel, sponsored by the Collaborative for Excellence in Learning and Teaching. And our presentation today will focus on living on the margins, or titled Living on the Margins. And we have three faculty presenters today, Professors Maureen Helgren, Leslie Neal Boylan, and Kevin Barry. I'll go ahead and introduce our three speakers, and of course they'll speak in the order in which I introduce them. Each presenter will speak for approximately 15 to 20 minutes, followed by a period of question and answers and discussion. Maureen Helgren is Associate Professor of Physical Therapy here at Quinnipiac University. Professor Helgren graduated from Quinnipiac College in 1983 with a degree in physical therapy and completed a PhD in anatomy and neurobiology at the Medical College of Pennsylvania. Professor Helgren comes to us from a variety of experiences in the medical field, including work in acute care, mainly in neuro-ICU and the burn unit, and postdoctoral work at a biotech company in developing animal models of neurological diseases. Professor Helgren has been teaching at Quinnipiac University's Physical Therapy Department for the past 18 years and continues to research in translational rehabilitation to meet the needs of underserved populations, and will speak to us today on some of her research in the paper titled I Am a Forgotten Man. Leslie Neal Boylan, our second speaker, is Associate Dean and Professor in the School of Nursing. She earned her BSN from Rutgers University, her MSN from San Jose State University, and her PhD in nursing from George Mason University. She's a family nurse practitioner and is also certified in rehabilitation nursing, home health nursing, and rheumatology. Dr. Neal Boylan has been studying nurses with disabilities for several years and has published widely on the topic, including a book, Registered Nurses with Disabilities, Professional Issues and Job Retention. Her paper today comes from her research and is titled Registered Nurses with Disabilities. Our third speaker, Kevin Barry, is an Associate Professor of Law at Quinnipiac University School of Law and co-director of the law school's Civil Justice Clinic, which represents low-income clients through a combination of direct legal services, community education policy, and policy advocacy. Professor Barry's research focuses on disability rights, employment discrimination, and the death penalty. Before coming to Quinnipiac, Professor Barry was a teaching fellow in Georgetown University Law Center's Federal Legislation Clinic, where he provided pro bono legal services to the Epilepsy Foundation and Large Disability Rights Coalition in support of their efforts to amend the America with Disabilities Act. Professor Barry received his BA from Boston College in 1998 and his JD from Boston College Law School in 2008. He was also a member of the team of disability rights lawyers that successfully negotiated draft legislative language with lawyers from the business community, resulting in the passage of the ADA Amendments Act of 2008. Professor Barry's paper today is titled Disability Queer, Federal Disability Rights Protection for Transgender People.
Thank you, Sasha. And I also want to thank Nancy Bagatelle for inviting me to this presentation. And I want to thank everyone who came out today to this panel discussion. I know that this is a really busy time for so many people, So it is difficult to come out to these events. So I really do appreciate it. And I want you to keep that in the back of your head, this concept of time, because I would like to use that to thread it through the talk that I have today, because time and effort is a component of thinking about how we approach disability in healthcare. So I have entitled my talk, I Am a Forgotten Man. This is my friend Kevin, a picture of my friend Kevin up there. I've known Kevin since I was in high school, and he and his family, we celebrate all the holidays together, minus the time that he and his wife separated and got divorced. And even then, they both still came to our family because they couldn't decide, who got us. And since that time, they have realized that that was a mistake, so they're back together. So they are still celebrating all the holidays with us. Kevin is about 55 or 56, I can't remember exactly. He has 2 adult children. He has 5 grandchildren. He is a builder. He's in construction. And he is an incredibly physically fit 55-year-old construction worker. He still does it all. He does the framing. He does the heavy work. Most people in construction at that age are starting to give that piece to the younger population because of their knees and their back and their rotator cuffs. Kevin is doing it all now with his son. They're in business together. Until about 8 or 9 months ago, when he went to visit relatives out west. There was no work, so he took advantage of the time through a series of very unfortunate events and choices. He woke up in a hospital out west with a cervical spinal cord injury. So he woke up and he could not feel anything below his shoulders. He could not voluntarily move anything below his shoulders, with the exception of shrugging his shoulders. He could do that. The nerves that innervate those muscles to shrug your shoulder come from the brainstem. So he spent a lot of time out west. He could not be transported. He wasn't medically stable to be transported back east for a few months. It was about 3 months. And also didn't have the money to be transported back until one of his clients paid for him to be airlifted back to Connecticut. His son had spent much of his time out west at the same time taking care of him while he was an inpatient. And this was 2 weeks after his son had his second child. So he had left his wife and newborn and 2-year-old at home. So Kevin, has since been back. He is still in rehab here. He's been to a number of rehab centers in Connecticut, again through a series of unfortunate events in our healthcare system. And a few weeks ago, his wife posted on Facebook that Kevin says he's a forgotten man, and pretty much broke my heart. This is Kevin, who I have known the majority of my life, and he is funny, he is in your face, he is smart, and now he's very isolated. He has a very supportive, immediate family, but it's hard for them, and it's hard for his friends to spend a lot of time with him. People don't understand, and he is feeling rejected. He is feeling isolated. He is feeling very, very alone. And he is not alone in those feelings. This is very common in the culture of disability. So I wanted to sort of use his idea of this isolation to think about what are some of the factors producing that isolation. And since I'm in the physical therapy department here and an educator here, I wanted to do a little bit of a twist on that. So my objective today is really to illustrate the role healthcare has in contributing to the marginalization of persons with disability. And hopefully, people would think that is a little bit odd, that you wouldn't think that healthcare professionals really contribute to a negative attitude toward persons with disability and contribute to their existence on the margins of our society. But I'd like to go through a little bit of thinking how the data and the research in this healthcare profession has contributed to marginalizing this population. So I'm not actually going to present any of my own data, as Sasha indicated. I am really just going to take some data to show how this concept of marginalization of the disabled exists. So what does it mean to be marginalized? I'm not really going to go through this. There are a number of words here to describe what it means to be marginalized. But what does it mean to be disabled? This is a little bit more difficult. Sometimes we get into some terminology, some problems with terminology. Sometimes we say the wrong things. We need a definition of disability, and we need to know what to call them, right? Already, that is putting somebody in this category. What do we call them? That's typical when somebody doesn't have the education and doesn't have the language to be able to describe this. One of the sort of common definitions of disability coming from the ICF, the International Classification of Functioning and Disability and something else, ICF, is that it is a multi-dimensional phenomena resulting in interaction between people and their physical and social environment. Gives us a little bit of idea of what disability is, but it doesn't really cover it all. Who is included in disability, and how can we really address this? I will use the terminology persons with disability. That is accepted in some circles. It's not accepted in all circles. It really depends on the cultural context of the terminology. Personally, when I think about disability, I think about disabled person, not of that person, but of somebody disabling that person, somebody else disabling. But for today's sake, I will use the term persons with disability. I'm also not going to go through the list of who is included in this group, because we can make that list. We can define that group in many different ways: physical, emotional, intellectual, psychological. I am just going to keep it in one large inclusive group, inclusive in this exclusive group. But when we think about disability, we have to think about the models of disability and how we have come to describe disability over the years. And there are really about 4 different models that have been characterized over the years. The first 2, the charity model and medical model, really came out of the time following World War II and thinking about a charity model. Here is a group of people that need to be pitied and we need to take care of them, versus a medical model which says here is a person with an impairment or with some dysfunction or with some illness, and here I am in the medical profession and I can help that person. I can help with their disability. Both of these models really put the onus on the individual, that it is the person who has the problem. And that might not necessarily be the best approach. When we use these charity or medical models, the expectation for independence is very low. We do not expect very much, only what we are providing. We're not expecting those individuals to have a say in their care. The medical model also was very focused on labeling populations, and we know that that is stigmatizing people, and that is not good. The medical model also reduces the needs of those individuals to an economic component, and that economic component doesn't necessarily take into account the entire sort of holistic approach. So in the 70s, late 70s, early 80s, the disability model was shifting to recognize that really the healthcare providers are part of the problem. They are continuing to be the leaders or the controllers of the issues. And when really it is the individual that has all the knowledge of what it is like to be a person with a disability. And that it is not the person who is the problem, but it is the society or the environment that that person is that then disables them. They still have an impairment perhaps, but it is the environment that is causing the disability. For example, my friend Kevin is a wheelchair user, and he now has some means of mobility. Our medical system got him to this point where he can have mobility based on being a wheelchair user. However, he can't get into my house now. I don't have ramps at my house. I don't have a way for him to access my house. There are places on our campus which are difficult to maneuver if you are in a wheelchair, and I have students here that can attest to that in looking at some of these disability awareness components. So it's really looking at the environment as being a disabling factor. Certainly the desire of the desired outcomes in this model of social disability is that the individual would be independent. So in the probably late 80s or 90s, it was recognized that this model also was not sufficient to meet the needs of this population. So the more current model of disability is really a citizens' rights-based model. it's really based on basic human rights, that there is interaction between the individual and the environment or the society that can create this disabling condition. There's a strong focus in this rights-based model of equal rights and equal opportunity. And when you have rights, with rights you have responsibilities. So in that model, it also incorporates that there is some accountability and responsibility and shared responsibility from a number of different levels. So when we think about disability and defining disability and understanding this population of disability, we really have to put it in perspective of what that model is. But what I really want to get to is how healthcare professionals can contribute to the attitude of disablement. And I think there's just 3 points I want to make here. And the first is that our education as healthcare professionals and our practice of healthcare really does focus on the medical model. We are trying to look at a disease process, an aging process, an injury process, trying to understand how that affects the human body, diagnosing that, and then treating that, being very diagnosis specific. And much of the research, and we are technically advanced, but much of this research that we have in the medical field, in the healthcare profession, is focused on that quantitative research, looking at diagnosis and treating. We are very in tune right now with this evidence-based practice, where everything has to have a very specific outcome. So that's one area where I think healthcare professionals are falling short. It is the methods of our research. It is our focus, perhaps, are spending too much time on the quantitative research, where we're not really understanding some of the needs that should be focused on. There's also a body of data looking at the attitudes of healthcare professionals. And one of the barriers to a individual's recovery or outcomes in rehabilitation is really the attitude of the healthcare professional. And you would think that is counterintuitive to what healthcare rehabilitation is. But in fact, it has been shown that one of the major barriers is a negative attitude of the healthcare professional. Again, it's this power level, perhaps, or this idea that I can do something for you to make you better, instead of really incorporating the needs of the patients. I'm not going to read this attitude, positive attitude component, except to say that one of the things that needs to change is this whole behavioral component. And in order for those behaviors to change, there has to, I guess I am going to talk about it, there has to be an underlying change at the affective level. And it's interesting here because Turvo and colleagues have talked about sensitivity toward positive attributes and liking the person. It doesn't mean you have to like every patient. It doesn't mean that I have to like every person in this room. I just can't dislike you because you have some condition. So I thought that was an interesting there's a lot of evidence right now looking at the attitudes of healthcare professionals, and maybe I'll get to it when we go through questions. The last thing I would just want to say about this contribution is a needs perception. There's also some data to show that oftentimes it's a healthcare professional who is making recommendations for outcomes and for a needs assessment for individuals. And the data shows that the needs assessment of a healthcare professional does not match the needs assessment of individuals. I'm going to skip that and come back to this model, because I did mention that the research, that quantitative research is part of the problem, is that we spend too much focus there. And when we come back to this human rights model or rights model of disability, one of the things that is interesting is that it really incorporates this integrative approach. It's this integrative approach of understanding disability, but it's also an integrative approach as to what to do with that. And when we think about disability and think about how to approach this now based on this human rights model, we can think about CBR as community-based rehabilitation, and just think about strategies which incorporate many different aspects of health and wellness and livelihood and education and empowerment. There's many different aspects that need to be incorporated into that. Getting the note. So I will end with this, not quite tied together, but the idea that some lives matter less is the root of all that is wrong with the world. And I will end, because I've been told to.
That was a wonderful foundation for what I'm going to talk about. So couldn't have asked for anything better than to have you present first, because it's really laid the groundwork for a lot of what I'm going to say. Hi, I'm Leslie Neal Boylan. I'm happy to be part of the discussion. I'm going to be talking about my research. I'm not going to bore you with any of those little dry areas about research, but I will speak about some of the data, which are narratives from interviews I've done with lots of registered nurses with disabilities. And the research that I've done involves, you got it? Nurses with self-identified physical and or sensory disabilities. So sensory disabilities, communication, visual, hearing. Physical, again, they're self-identified. So some people talked about having chronic diseases and how that was, they saw that as disabling for themselves. A lot of musculoskeletal impairments, severe allergies, all kinds of, and again, because it was self-identified, it was what the nurses themselves thought caused for them to have, they felt it was disabling to them. And so I came up with originally doing this because I knew there was a lot in the literature about students, nursing students with disabilities, and typically in schools of nursing, we like the students to be very able-bodied because they're going to do a lot of physical work. And there wasn't anything out there about, once you're a registered nurse, being disabled or having a disability, and yet nurses are aging, and so this is something that we're facing more and more. And we have ebbs and flows of nursing shortages, and we need nurses. So I did these interviews, and the data that came out of it really showed a lot about what you were talking about in terms of discrimination. And maybe the medical community isn't they're too paternalistic, and they're not as supportive of people with disabilities because they're not supportive of each other either. So I wanted to just start by reading you about Sue to sort of set up the background for this. Sue is a 54-year-old registered nurse with 30 years of nursing experience. She's always been a hard worker, and she has extensive expertise and experience as a critical care nurse. She's always prided herself on being able to care for her patients without needing to ask her colleagues for help, except in extreme situations. Sue was diagnosed with rheumatoid arthritis 5 years ago, but never mentioned this to a supervisor or colleagues. However, in the past year, she's began to feel very fatigued and in frequent pain. She found herself asking other staff to help her with tasks she could previously manage on her own. She's also been using her sick leave and taking more time off than she's ever taken before. Her manager suggested that Sue might not be capable of doing this kind of work anymore, and asked if it might not be best for her to leave critical care and work in another area of nursing. Sue was shocked and dismayed to hear her manager speak to her this way, and assured her that she could do the work and that she wanted to stay on the unit. Sue found her own ways of compensating for what she could no longer easily do, but sensed that her colleagues did not approve of her compensatory techniques, even though they worked well and did not compromise patient safety. Not long after this, Sue had her annual review. Despite having had excellent reviews every year, this review indicated that her manager was not pleased with her work. Sue decided to leave the job. She was not given any information by the manager or by a human resources representative regarding her disability rights before she left, nor was she given any specific options for working in another area of the facility in order to stay there. So nurses know if they feel like, very often nurses will leave the area they're working in because they feel like they're going to jeopardize patient safety. And they know if they can't continue to work in an area such as critical care. But to date, there's been no documented evidence that a nurse having a disability has contributed to an injury to a patient or jeopardizing patient safety. So they are being pushed out of their jobs, however, because other people make the assumption that they are jeopardizing patient safety. The Center for Disease Control says that approximately 71 million people in the U.S. have disabilities. Of these, 16 million have problems with mobility, 35 million with trouble hearing, and 19 million have trouble with their vision. It costs the U.S. government about $230 billion annually to support employable adults with disabilities who are not employed. And there's a high demand for nurses, especially for those with experience. So why aren't they employed? Registered nurses provide health care to people of all ages across all settings, and there's been enough research to show that having an RN take care of a patient greatly improves patient outcomes and improves the quality of patient care. And when we have tried in the past to replace them with unlicensed personnel, terrible things have happened. People have died, there's been a lot of complications, so we know that it's important to have the RN. But nurses with disabilities are leaving the profession, and they're leaving for three main reasons. They're discriminated against, as you were discussing. They don't always know their rights, and they don't know how they can stay in the profession despite having a disability. And most of these nurses have a lot of experience. They have expertise and experience, so it really hurts all of us if they leave, because we're the ones who are going to suffer, and we need to find a way to keep them. So we don't know how many nurses in the U.S. have disabilities. We do know that people with disabilities in general more likely to be self-employed, work part-time, and are less likely to be in management positions than people without disabilities. Now I want to read for you now about an experience that one of the nurses in one of my studies had, and she had arthritis. A lot of us have arthritis. She was a very experienced nurse. She applied to work in home care hospice, so in a home care setting, providing care to dying patients. And she says, hospice needed nurses desperately, and I gave them my resume and they loved it. They thought it was wonderful. They called me right up. They asked me to, quote, please come right over, unquote. In the interview, I'm sitting down and I look like I'm perfectly normal. You'd never know. And then as I stood up, well, they shake hands with you, so you need to stand up. I could just see the face go. They see my posture. They just see a workers' compensation case. I can see it in their face right now. I should have just turned around and left then. They're obligated, though. They've known, because of discrimination lawsuits, they have to interview me. And almost every single job has given me a second interview just to make sure I don't file anything. So she offered to be precepted. She offered to have somebody go out with her and see what she could do. She offered to take less money. She said at the end of all of that, I said, you can check me over. See if I'm able to go out and do home cases myself or not. I said, there's no obligation on either side. You don't have to give me benefits. You don't have to do anything, but it's helping me, and at the same time you're getting an RN. They didn't even call me back. I wrote them a repeat letter back saying, I don't know if they received my first letter. I just wanted to follow up, and nothing. Nothing. So she continued to apply for jobs in home care, thinking that would be physically easier than working in the hospital. And she had a lot of psychiatric mental health experience as well as end-of-life experience. So she decided to apply to a home care agency that, quote-unquote, desperately needed psychiatric mental health nurses. And when they got her resume, they called her up and they said, would you mind? We really need psychiatric mental health nurses. Come right now. She says, I go over there. And again, sitting down, I'm fine. The minute I stand up, the lady's face, I can see it. I could tell the receptionist as soon as I came and told her who I was and what I was interviewing for. She got on the phone. I heard whispering behind me. I think she was calling this lady to tell her, hey, you don't want this one. When the receptionist prepared to take the nurse upstairs for the interview, the receptionist suggested that they take the elevator, saying, I don't know if you can do the stairs. The nurse answered, I have no problem doing stairs. If you like, I'll be happy to do them for you. She made me do the elevator. We did that. I think I had the world's quickest interview, 2 minutes flat. Then she actually had the audacity to take my elbow and hold my arm as I walked out of there to meet me out downstairs to get me out of the building. I left there in tears. So a theme that's come up over and over again in my research is that nurses, when they can, hide their disabilities. They hide them in interviews, and if they acquire the disability while on the job, like Sue, her rheumatoid arthritis got worse, they do their best they can to hide it because they are discriminated against once anybody knows that they have a disability. And employers don't give them a chance to see what they can do. So this was another nurse. She left traditional nursing for non-traditional nursing because she had a lot of barriers against her because of her disabilities. She said, they would not let me do many things, so I hid the disability. Try to do the best you can. In my case, I could hide it. I could literally hide it, not to have to let people know it was there. But there were attitudes regarding people with disabilities. The attitudes that if you had a disability, you weren't good enough, or you couldn't do it, or we won't let you do it. And then another issue is that when a nurse does need to leave the facility, nobody seems to, and this seems across the board, nobody has a conversation about what their disability rights are, or if they're ill, FMLA, family medical leave, what their options are. Nobody says, well, you know what, you have great cardiac expertise. You may not be able to work in our cardiac critical care unit, but guess what? You could monitor telemetry, which is essentially looking at a computer and watching somebody's heart rate, and you could let the other nurses know if somebody needs to run down the hall. Nobody makes that attempt to retain those nurses, and that's a serious loss. Nurses have been told that having a disability compromises their ability to provide safe care, but again, there are no documented cases of that. It's an assumption people make. So they don't hire them if they fear they're going to jeopardize patient safety. In reality, they compensate for what they cannot do, and they can provide safe care. And if they can't do so, they leave. And they look for something where they can. The nurses themselves don't want to jeopardize patient safety. Now, an interesting thing about one of the studies I did was looking at physicians and nurses, and we compared the experience of physicians and nurses with disabilities, almost exactly the same. So you're talking about the medical community. Not only are they not being supportive of people with disabilities on the outside, but they're not supporting each other. And the physicians found the same kind of situation. They could compensate. There was one, I know I'm getting off from nurses to physicians, but it's an interesting experience that he was an emergency room physician, and he had compensated for what he was not able to do the traditional way. It was very safe, worked really well. He was told, you need to leave emergency medicine and you need to do a residency and become another kind of physician. So this was very consistent with their experience as well. The other thing is that nurses feel like they have more empathy for patients, and the physicians felt that way too. They understand how it feels to have an issue where nobody is really taking you seriously, nobody gives you respect for what you know about your condition. You have to do things somewhat differently than other people may do them. And patients report that they really feel like those healthcare professionals understand them better. Most nurses have a hard time taking time off. We have this whole thing that I call nurse heroics, which really is not so much running onto a battlefield, although we do that too. It's saying, I need to go eat. I need to take a coffee break. I need my vacation. Or, horror of horrors, I am actually taking my sick leave. Because you're supposed to be self-sacrificing, and you're supposed to not need to take time for yourself. Interestingly, even Florence Nightingale said, what's now 150 years ago, said nurses need to take care of themselves because they can't take care of other people unless they do. And yet we have this culture that we're not supposed to do that. And you would think with a nurse with a disability, his or her colleagues would support them and say, you need to go eat, you need to go sit. It's even worse for them because they're thought of as slacking. You can't do this right now. It doesn't matter that you're willing to do something for me and I'm going to do for you what you might not be able to do. You can't do what everybody else is doing. You're considered to be a slacker. So I want to read you one more quote about that. And this was another nurse with a disability who said, my experience in talking with other people in the field or working with other people in the field is that it's the same sort of expectation to mask or to go past whatever physical limitations you might have, to not bring that to the table, to not say, I really need you to modify something. I think there is that expectation you are the strong person, you're the nurse, you're the caretaker, not the one that other people are supposed to be taking care of. And that's another piece of nursing about what you'll do for your patients, but not for yourself. So I think in conclusion, we really need to frame the way we think about all persons with disability. This work with nurses is just, I think, an illustration of what a lot of very employable people go through, a lot of assumptions being made about what they can and cannot do without giving people the opportunity to demonstrate that. We lose people who have expertise, education, experience, when we really should value them and find a place for them so that we can benefit from what they have to offer. Thank you.
Hello, everyone. Tough acts to follow. Those were great. And I think they're actually going to connect pretty well. It was stiff competition when I last did a scholarship across the disciplines. It was the royal wedding, and I think there was like a moon bounce out on the quad. Booze was flowing like wine. I don't know. I made that part up. But there was anyway. We were a lot leaner than we were today, and this is really exciting. So anyway, I think our three pieces actually will connect, and I'll talk a little bit about how they do. I'm gonna do some things on the fly. But as I was introduced, my piece that I'm working on now is called Disability Queer. By the way, so I'm over at the law school. I teach in the civil justice clinic. So much like a medical school, Quinnipiac's medical school has a teaching hospital, Every law school in the country has a teaching law firm. Many have several. So that is where I am housed. The paper I'll talk briefly about today is going to be published in Yale's Human Rights and Development Law Journal, right down the street. This is part 2 of a project that I talked about a year and a half ago that you may have missed on account of the royal wedding. Part 1 of the project dealt primarily with autism and this concept of neurodiversity that some in the room know a lot about. This is part 2. But if there's echoes of some of that, you don't think that I'm just a really, really slow writer. It is, in fact, the second piece. Okay, let's start with, though I am kind of a slow writer. All right, transgender basics. Here we go. Okay. So, just a few linguistic things to get out of the way. The term transgender has to do with one's identity. So this is an umbrella term that describes those whose gender identity or expression doesn't match their assigned gender at birth, assigned gender based on anatomy. Gender identity disorder, or GID. Now, by the way, gender dysphoria. When I use the words DSM, do folks know what I mean? Okay, so that's the American Psychiatric Association. All hell's breaking loose, and they're issuing a new edition in 2013. You will start hearing the word gender dysphoria. But anyway, I'm going to use GID for purposes of clarity, and because that's the term that's currently used under the law. Okay. Anyway, gender identity disorder, a medical impairment that refers to an incongruence between one's experienced expressed gender and assigned gender of at least 6 months duration. Some sobering statistics. Give them a read. I won't read them out. So if there's a few takeaways that you get from today, simply, don't be a discriminator. Be a good friend. Be a good family member. A good employer when you're out there. Okay. And if anyone wants to do something on November 20th, I'm game. But perhaps we should talk to Diane on that. That's right. I mean that. Anyway, let's talk about it. Okay. Slide 4. And by the way, I should say, in International Transgender Day of Remembrance, what is that? There's actually a day that is dedicated to the memory of those who have been murdered or brutalized because of their being transgender. Okay. Slide 4. So we've heard murmurings and a bit of disability rights. So the preeminent law that we're talking about when we talk about disability rights is the Americans with Disabilities Act. So I'm just going to give you the quick 101, and I won't bore you to tears. The ADA is a comprehensive anti-discrimination law. Anti-discrimination, prohibiting discrimination against people based on disability. Prohibits it, why comprehensive? Because it prohibits discrimination in a range of areas. So there's the big 3: employment, public services, places of public accommodation. Places of public accommodation is like the restaurant, the hotel. Public services, of course, would incorporate your public parks and so forth. Okay. And what's interesting, well, maybe I can just touch on it right now. What we've heard today, some of these references to disability rights, we've heard about various folks. We heard about Maureen's friend. And so he cannot move his arms and legs. What is his diagnosed condition? Do we know? It's just
Spinal cord injury.
Spinal cord injury. Okay, so here is spinal cord injury. Now I'm going to draw a bigger circle. We heard about a nurse who had, it was arthritis, right? Okay. Now what we talked a little bit about today is the distinction between disability as it relates to kind of, this sort of a medical kind of condition, disability under the law, anti-discrimination. These are different kinds of definitions. Definitions matter. Under disability law, under the ADA wanted to protect folks like this gentleman. And probably always has and always will. It's very obvious. This gentleman cannot move his arms, his legs, he is disabled. Well, the ADA actually sought to do more than that when it was passed back in 1990. It also wanted to protect the person with arthritis. Maybe the person who visibly you couldn't really see and in fact couldn't shake hands but could do the job and so forth. But for reasons I'll get into, it didn't. It didn't protect this outer circle. Enter the ADA Amendments Act in 2008. It went to protect these folks. So if you talk about, I guess if we use kind of a baseball metaphor, we were protecting the folks who were, right at the center here. Then we protected this second ring with the ADA Amendments Act. But there were some folks who never got out of the dugout, who were excluded from the get-go and have remained so. And that's what I'm going to talk about here. That's GID. So that's our disability universe of ADA coverage. All right. Well, I said GID, but I should add homosexuality and bisexuality. All right. So let's just call it sexual orientation. Okay. So homosexuality and bisexuality, from the get-go in 1990, were excluded from the ADA. They are not impairments, and as such, they are not disabilities. Remember, ADA talks about disability as this impairment. Or actually, let me go back. A person has a disability if they are treated unfairly based on a medical impairment. The medical impairment really is the basis. Homosexuality and bisexuality aren't impairments, so therefore they can't possibly be disabilities. We're going to exclude them from the get-go. But then it did something else. This was the second paragraph. The second paragraph of exclusions. We're going to exclude transvestism, transsexualism, pedophilia, exhibitionism, voyeurism, gender identity disorders not resulting from physical impairments, i.e. a gender identity disorder contained in the DSM, this mental impairment. We're also going to exclude compulsive gambling, kleptomania, pyromania. We're going to exclude psychoactive substance use disorders. Okay, so long story short, notwithstanding the fact that transgender people are discriminated against, you saw the statistics, on the job, in school, and elsewhere, because they have transitioned, because they are in the process of transitioning, because they intend to transition, or because they otherwise defy gender norms. Congress wrote them out of the ADA in 1990. Now, some folks might be thinking, especially with my little diagram here, this sounds right. Gays, lesbians, bisexuals, no, they aren't included. They're excluded. Transgender people, kind of the same. So they have no business being in the ADA. They don't have medical impairments. But take another look at the exclusions. So homosexuality and bisexuality are excluded from ADA coverage for a very different reason than GID. They're excluded because they are not considered impairments, so they are not disabilities. According to the ADA, GID is an impairment. It's just not the kind of impairment that Congress wanted to protect. So we've given some personal stories. Let me give you a quick one. When I was writing this piece, Disability Queer, I decided to contact a family member on my spouse's side. One of the first to go through a transition back in the early 1970s. I mean, cutting edge. So I crafted this very nice email. She was a male to female, a trans woman. So I crafted this very nice email. It was beastly long. I'm not all that tech savvy, so I told my spouse, hey, should I send this via the Facebook thing, you know, the private email thing, or do we have an email address for her? I guess there's a way you can send like private through Facebook, or anyway, my spouse said, no, why don't you just email this thing? And she had an email address. Well, it turns out the email address my spouse sent it to was this woman's work email, and all these things can be read. And to which she immediately responded, and then responded again the following day, saying, I have to meet with HR. This is bad, bad, bad. So you're this woman now. Now, if you were one of these two folks, you know you got some coverage under the law. Now, can you in fact make out a case? Will you be successful? Maybe, maybe not. But at this very threshold level, you're in the ballpark. With this woman, she absolutely was not. She's not covered under the Americans with Disabilities Act. State law may be a little different. She actually is from Florida. She doesn't have protection there. Some movement going on in EEOC land, but basically, this woman has no protection. And that's the difference. Now, here's a quote. 1989, Senator Jesse Helms. If this were a bill involving people in a wheelchair or those who have been injured in the war, that's one thing. But how in the world did you get to the place that you did not even exclude transvestites? How did you get into this business of classifying people who are HIV positive, most of whom are drug addicts or homosexuals or bisexuals, as disabled? What I get out of all of this is here comes the US government telling the employer that he cannot set up any moral standards for his business by asking someone if he's HIV positive, even though 85% of those people are engaged in activities that most Americans find abhorrent. He cannot say, look, I feel very strongly about people who engage in sexually deviant behavior or unlawful sexual practices. Now, Senator Helms is doing all sorts of conflating in this paragraph. So HIV equals gay, gay equals drug user, transvestites equal transsexual. They're very different. But you get the flavor. The takeaway is that the GID exclusion was based on nothing more than morality. The ADA, from its very inception, was a moral code. Disability coverage applies to those we pity, not those we despise. Transgender is bad, and we, Congress, do not pass laws to protect bad people. So here are three very simplistic ways of thinking about being transgender. Transgender is good. Being transgender is as good as not being transgender. Transgender people, like gays, like lesbians, like bisexual people, they're just like other people. The middle view, transgender is unfortunate. Transgender is not good, but it's not inherently harmful. It's unfortunate. Are you sensing this kind of medical model, disability kind of thing? And then there's the third. This is Helms. Transgender is bad. Being transgender is morally harmful, depraved, reprehensible. Pick your adjective. This is the view codified under the ADA. So here's the impact. Rachel Maddow, openly lesbian, host of MSNBC's Rachel Maddow Show. She's excluded from the ADA because she's not impaired. Gay, lesbian, bisexual, so one might extract from this, is good, or it's at least becoming good, consistent with the first moral view. Jerry Sandusky, this is the gentleman at the top, flanked by two officers. So he's the former defensive coordinator of the Penn State football team. He was arrested in 2011 for sexually abusing 8 boys over a 15-year period. He's excluded because his behavior, his impairment, is morally reprehensible. Pedophilia is bad. And here we have Chaz Bono, the child of Cher and Sonny Bono, a trans man who was a competitor on Dancing with the Stars in 2011. He too is excluded because his impairment is morally reprehensible. So transgender is bad, according to the ADA. Okay, slide 10. This is what I talked quickly about, and the intro talked a little bit about some of my work prior to coming here to Quinnipiac. It's 2008. All right, Congress could have changed all of this with the ADA Amendments Act. Remember what I said, essentially what you had is years and years of court decisions that were narrowing this definition of disability, narrowing it so that the only people who could get disability rights were those who were severely functionally limited. Congress comes in and says that's not what we meant to do, guys. We meant the definition to be far broader than that. We meant it to include people that we don't typically think of as disabled. We typically think of people as disabled as people who can't work. Well, the Americans with Disabilities Act is an anti-discrimination act. It's for people who can work, but people who won't even let them in the door because they can't shake hands. You see where I'm going with this. Very different than, for instance, like SSI. Yeah, that's for people who can't work, right? Okay. So in comes the ADA Amendments Act of 2008. It blows the definition of disability wide open. So wide that everyone in this room is covered by the ADA if you are treated unfairly. Let me say that again. Everyone in this room is covered if you are treated unfairly based on an impairment. So if I ask for a show of hands for everyone that doesn't have an impairment, no one's hand should go up. I've got my psoriasis right here. And if I had it in my hairline and somebody decided to deny me a job, I'm now covered under the ADA. Well, what about Chaz Bono? He's still not covered. The ADA Amendments Act did nothing to change the ADA's exclusions. So what do we think about this? What can we do to make transgender good? So option 1, let's leave the GID exclusion as it is, and let's work for passage of other state and federal laws. Option 2, well, let's revise the GID exclusion. Let's clarify that GID, like homosexuality and bisexuality, are not an impairment. Remember that kind of two-step that the ADA does. Homosexuality, bisexuality, they're excluded from the ADA because those aren't even impairments. These other ones, they are. Those people are sick. So another fix might be let's move GID up into homosexuality, bisexuality land. Option 3, eliminate the GID exclusion altogether. So I think the third option, and I argue in the paper, is the way to go. And I can talk more about it if folks would like me to. In a nutshell, I think that removing the GID exclusion is the best way to provide important rights to transgender people while also removing the stain in federal disability law. The stain that likens people with GID to folks who hurt others, and burn and steal things. All right, before I finish, let me know just a few specific questions that I addressed in the paper, and I'm happy to talk about these as well. 1989, perfect. How exactly did the GID exclusion get into the ADA? I've given you some of that flavor, Senator Jesse Helms. We're talking about 2, maybe 3 senators, if you're keeping track. Helms was one of them. Another was Senator Armstrong from Colorado. An 11th hour backdoor deal that resulted in the exclusion of GID. Let me just read you an excerpt from the piece. Disability rights advocates had whittled down Senator Armstrong's 4-page list of exclusions. Senator Armstrong originally had like 4 pages copied from the DSM. So he just wanted to exclude them all. Disability rights advocates came back with about 5 conditions. GID wasn't on it. I think kleptomania was. After receiving the revised list of exclusions, Senator Hatch himself, it's a big deal, comes out into the Senate antechamber, tells the disability rights advocates that he, quotes, needs some more. One after the other, GID and approximately 6 other conditions found their way onto the list and out of the ADA. All right, 2008, why didn't the GID exclusion come out? I talk about disability rights advocates, their reasoning as to why the ADA Amendments Act should leave the GID exception alone. Long story short, the ADA Amendments Act, back when it was evolving 2006, 2007, was originally called the ADA Restoration Act, restoring Congress's intent. Can you say with a straight face that in 2008 we're going to restore Congress's intent by removing the GID exclusion? That Congress originally intended back in 1990 to protect people with GID? No, they didn't. They intended to protect the nurse with arthritis who was excluded. By the way, I don't think I spent a lot of time on this, but this middle paragraph here, these are the folks that are now covered under the ADA Amendments Act. This is from actual cases. These are folks who never would have been, who were not protected originally as courts were construing the definition. So when you start to look at these, and then you consider what folks with GID go through, why on earth are they still that separate planet in the disability rights universe?
So that's the list from the 208, 2000.
Correct. So this is not a list that's written into law. Recent cases have said, okay, under this new definition, these are disabilities. These are now disabilities. So when I kind of say that all of you have you had ankle injuries and so forth. What happened in these cases is a person was fired. Person generally fired, generally not hired. Those cases are notoriously more difficult because of an ankle injury, because of anxiety disorder. In some cases, person was not given a reasonable accommodation based on this. That too is discrimination. The court found that these people are covered under the ADA. So this is an example of that expansion that I'm talking about, the intended expansion. So the takeaway is the ADA Amendments Act is working. Not as well as we would have liked, but it is working. Okay, so then the future. Why should GID be excluded now? I talk about some arguments for and against the GID exclusion from the standpoint of the transgender community. For instance, do transgender people really need this protection at all? And even if they do, would classifying them as having a disability really make transgender good? Or would it stigmatize transgender people even further, essentially locking them into that second moral view we talked about? Transgender is unfortunate. So, that's all I have. Thanks very much.
Wow. Thank you very much to our 3 presenters for very fascinating and interesting presentations. The floor is now open for questions, comments, discussion.
I actually have a question for the third speaker. I would think that those individuals would not want to be classified as disabled, as there's something wrong with me, because their argument, and we hear this a lot even in disability studies in general, that they don't like rehab because rehab is always telling them we have to fix you, and their response is there's nothing wrong with me. This is who I am. So that's where I have difficulty covering them under ADA, because they don't have to be fixed. There's no real disability there. That's who they are. And I think that's why it would be, in my opinion, better to put them in the category with the bisexual and homosexual rather than cover them.
So let me give you my, that is absolutely a concern that's out there, and it's got a lot of merit. When we talk about that transgender umbrella, there's what's colloquially known as transsexuals, folks who have every intention of transitioning, whether that be through hormones or whether it be through actual surgery. There's also the more amorphous gender queer. Are folks familiar with that term? Folks who are blur these notions, these poles of female and male, who dwell somewhere within or outside of. I think that comment you would more likely hear from the gender queer folks as opposed to the transsexual folks. The lawyerly kind of answer is, under state law, some state disability law, folks have had a lot more success under state disability law than under, say, state sex discrimination law. There is no federal protection for transgender folks. There probably will not be any for a long time. So you kind of see where I'm going with this. But what could the ADA possibly give to transgender people? It could give them time off, much like FMLA, which is unpaid. Under the ADA, there's a requirement for reasonable accommodation. It's a big deal. If you're going out for some counseling, for your meeting with a psychiatrist, psychologist, to work through some gender issues you're having. What about that dress code at work? How about pronoun usage? My boss keeps referring to me as him when I'm dressing in feminine clothes because I'm preparing for my transition. What about pronoun usage? What about bathrooms? I am now presenting and living full-time as this other gender. I am going to use that, but even though that's the one that's always used for the old boys, where everyone smokes, this sort of thing. Other laws don't provide what the ADA does. So the ADA provides lots of protection. So I think that's the left. And then the right is, so if the ADA provides all this stuff, and we can agree about that, the ADA gives more, then what's the downside? It's what you point out. It's this disability. What I'm saying is, under the ADA Amendments Act, disability has changed. If the person with psoriasis now is disabled, the person with an ankle injury is disabled, you saw it, they are, then why not have a person with GID be covered under that same law? The issue of legitimating the DSM diagnosis is another real touchy one. Even if you say, yeah, under the ADA, whole thing's changed, everyone's in there, I agree the ADA would be a good vehicle. In fact, I even agree that disability isn't such a bad thing after all, but I just really don't like another law saying that this DSM diagnosis is okay. There's many people who want the DSM diagnosis out of the DSM. There is no such thing as gender identity disorder. I guess my quick comment to that is the ADA already says that they have an impairment. It already recognizes DSM. It just says they have the kind of impairment that we're not going to protect. So if you get it, if it recognizes you have an impairment, well, why not have the kind that they do protect? A really legitimate debate. And I guess I would say, and this is from a recent case, so another takeaway, and this transgender issues are everywhere. So a recent case just a couple weeks back, this is the Massachusetts Federal District Court case saying that Massachusetts Department of Corrections has to pay for the transition surgery of one of its inmates. In that case, they talk about the condition that this now trans woman has, which is GID, how she tried to self-castrate herself in a cell, how she tried to commit suicide several times. You saw the awful statistics. Here's one court. Surely, had the legislature passed a law that Department of Corrections inmates with cancer must be treated only with therapy and painkillers, not surgery, this court would have no trouble concluding that the law was unconstitutional. Refusing to provide effective treatment for a serious medical condition serves no valid penological purpose and amounts to torture. I read this with recognition that there are at least members of the transgender community that really do believe that this is a medical condition. Be it physical, I think more believe that, some mental. and that you respond to a condition the same way you respond to other conditions, like cancer. I think autism's a great example, though, of the community that's going to come back and say, don't fix me. There's nothing wrong with me. Don't compare autism to cancer, which people do. But here you have it in a court case where they're comparing GID to cancer. So, does protection, does it further that? Really tricky issues. I think what we're looking at in GID land is a continuum. And I don't see, the lawyer in me doesn't see the downsides. And I will say, not to support my point, but the lawyers that I've talked to in the trans community say the same thing. I had one read the paper and she said, these comments you're bringing up about the transgender community saying don't do that, I don't hear it. It's out there. We see it in the blogs. But the people in the driver's seat steering the civil rights, it's interesting. They say, get me that tool to get me some rights.
A couple of things. Your comments. How to take your comments with this ADA that's for some people trying to do something good, but not for other people. But on the same token, its whole premise is based on what is an impairment, meaning that there's something wrong with you essentially. And your point was it's a problem to call things impairments because it puts a label on people that they then are impaired in some way, and somehow that's not the ideal situation. How to come to terms with those two things. But to me, I think there's a broader problem in, you talked a lot about the medical profession and how it contributes to that. I think by the virtue of the fact, to some extent, that it has diagnoses to begin with, but that is kind of the foundation of medicine's practice. I would like to point out that nursing is a little more broad-minded. We don't teach the medical model. We do teach a person-centered approach, but I think the larger problem where that doesn't come through is really a societal issue and what the values are in our nation, and looking at, because healthcare providers are people first. And, the examples of, the senator and how they treat people, and the nurses, how they treat, their colleagues. But also I think about the school systems and how, a child who doesn't fit into the public school's way of teaching is somehow, must be something wrong with the kid. It's not something wrong with the system and how we teach them, so we need a label for them in order for them to get any kind of services that helps them to be able to adapt to our environment. We don't adapt to the child. And so I see this as something that's very pervasive in our country, across all disciplines and, individuals. There's a lot of bias out there.
There's a lot of bias out there. And some of it is unconscious bias, some of it is conscious bias, and part of that is really that it's our role as educators to start exposing those biases and exposing the ways to approach people, our individuals, ourselves, as well as other people. And it's that holistic approach. It is that person-centered approach.
Well, is it true, would you say, isn't it true that in a perfect world, we wouldn't need the ADA anyway? Because everybody would be treated the same. So it's trying to grasp in my mind, it all came about with the way back, what was the date of ADA? So it all came about when...
But actually, it goes before that. Maureen, you did a nice job kind of framing the different sort of years and models. I really like that. The ADA was based on the Rehabilitation Act of 1973. It's really interesting. Like we talk about, and I don't want to keep monopolizing time, but this is kind of interesting. You read the Rehabilitation Act. Well, don't read it. It's ghastly boring. It's really long. It's really dense. It has to do with providing vocational rehabilitation services. So the model, Maureen, of Rehabilitation Act would be, it's like this sort of medical model kind of thing. But then there was this little paragraph they tucked in, about 40 words. And it said, and you also can't discriminate against a person with a disability. just tucked it in at the end. The thinking was, well, if we provide all this great vocational rehabilitation stuff, if we allow that woman with arthritis actually to be able to get up and get to her job, and then somebody doesn't give her a job because she can't shake a hand, well, then we've just defeated the whole purpose of the Rehab Act. So we're actually going to have an anti-discrimination mandate of 40 words. Well, then that developed over the years, and it was only applicable to the federal government. 1990 comes out and did something radical. We're going to make this applicable to private employers, to private restaurants, private hotels. We're going to make those buses kneel. We're going to make the aisles in our trains wider. I mean, this was a really comprehensive, radical measure. Civil rights, absolutely. So it goes back a little earlier than that, though Rehabilitation Act was more under the radar, I think. 1990 really brought disability rights really up.
But I think a big part of the issue is we have it, and yes, there are obviously problems with it, but even for those people that are supposedly covered, they're not getting the benefit of it. I mean, I heard story after story of ADA being violated, you know, and part of ADA is you're not supposed to harass somebody with a disability. And I had examples like one nurse talking about her manager, this was in the hospital, called a special staff meeting, went around the room and asked each of the staff to comment about what they felt about her disability. I mean, that's she said, I felt like I was in the Inquisition. You know, that's unconscionable. So even people that are supposed to know, managers, HR people that are supposed to know the ADA are not really complying with it.
And another example, Nancy, maybe I'm stealing the words out of your mouth, but so Nancy's done a ton of writing in autism and neurodiversity land, but one thing that we heard a little bit about is people deliberately hiding their impairments so that they don't have to deal with this retaliation.
That's exactly what I found.
Can I just ask a clarification for both Leslie and Kevin's paper? So for nurses who experience this discrimination, have you encountered any who have sort of taken the next step, which is an attempt to secure their rights through this Disability Act 1? And for Kevin, how would a person go about sort of proving this discrimination? Because it sounds to me, Leslie, from the cases that you described, that there is an assumption or it's almost implied, but they haven't really done anything except for this last one that you mentioned. Those who are discriminating against a nurse haven't done anything explicit that you could say, aha, you know, this is the material evidence to support that you have discriminated against me. So what have the nurses done? And for Kevin, how would you prove this discrimination?
Well, there were some nurses who were advised by attorneys that they talked to that they did have cases. Very rarely did they pursue them because they were worried about then what would happen with their future employment. But in most cases, they had no awareness of whether it would be a case or not, because they also were not as aware as we all should be about what their rights were. And so they didn't even think about consulting an attorney about it. And that's a problem.
And it starts with consulting an attorney oftentimes, or what we see sometimes in the clinic. I mean, folks who are low income and can't afford an attorney, there are state agencies out there. So here it's our CHRO. The federal corollary is the EEOC, and that's where you file your complaint and you send it on in and you wait. And you wait, and you wait. And essentially what the agency's trying to do is to do a deal. So, but basically they're going to meet with the employer, they're going to sit down, what happened, kind of interview, do this sort of thing, back and forth, back and forth. At any moment, a person can kind of put the brakes on that and pursue a court action. I mean, what would they have to demonstrate? I mean, what you're leading us to, coverage is only like part of the battle, like, yeah, I'm protected by this law. It's also, well, you have to show that you were actually qualified to do the job. It wasn't that you have carpal tunnel or arthritis, it's that you only have a high school education and this thing required a college education. That's not disability discrimination. So there's qualifications, and there's also the causation piece. You were super qualified for this job. The reason they didn't, and it often comes up when you actually have the job, the reason you got fired wasn't because you have a disability. It's because you drink too much on the weekends and you never come in on Monday. You know, it's just bad. You're a bad employee, this sort of thing. What the ADA gives, though, the real teeth, is this idea of reasonable accommodation. So once the person, for instance, is in the job and they now have this this disability, this impairment. They sit down with their employer, and the words that are used is an interactive process. So for instance, if you guys have friends out there, who get injured on the job and so forth, who ask, what are my rights? After the ADA, it's not you're injured now and so forth, you're fired. It's what can we do for you? And the employer's defense could be, look, there's nothing I could really do for this person. They essentially are no longer qualified. I can't even accommodate them. I can't create a new position out of nothing. But oftentimes they can. They can do these things, which you had described, which I think you had described as well. Well, maybe we can just have them put in front of the monitor. And then if something does require an emergency, we are going to call the nurse who does not use a wheelchair or so forth. This idea of reasonable accommodation. Employers being reasonable. When you read some of these cases, it makes your head spin. It's just employers being completely unreasonable. It's employers who don't know the law, let alone the employees.
Just a couple of things. Well, first off, I do support groups for adults on the autism spectrum, and they all talk, we have this conversation, I would say almost every other month, about whether to disclose or not to disclose at work, and they all basically will tell new people in the group, do not disclose that you have autism spectrum disorder at work, because regardless of, your coworkers are not going to get it, and it's going to be uncomfortable. So there's this whole stigma about whether you even just disclose. But I was going to ask Leslie, your research is beautiful, and I'm wondering what you hope will come from it.
Oh, thanks for asking. I'm actually trying to take steps. I've talked to the American Nurse Association because they have an initiative for a healthy nurse, and trying to talk to them about, because a lot of what came up repeatedly with studies is that nurses said a very practical thing that would help them is if there were some kind of monster.com kind of thing where you could put in your education, your expertise, your geographical location, what you can do rather than emphasis on what you can't do, and find out what jobs are available in your area, so that if you can't physically do the job that you have, you can find something else rather than leave the profession altogether. So I'm trying to work with the ANA to see if something like that could be developed. I just was on the phone with someone in Connecticut who, forget her exact title, has to do with disability rights and legal rights for, I think, women, especially in Connecticut, and had a conference call with her, and we talked about increasing awareness and trying to make people more aware of their rights, and we'll see where it goes. But I'd like to do something concrete. So if you have suggestions, I'd really appreciate them.
What I think is great about that approach is law, by definition, a lot of times is backward looking. It's like something's already happened. And by the way, for a case to be brought, you're talking about over a year of litigation. They had to go to it's absurd. And so what the EEOC, for instance, is trying to do is to lean on some law professors who get paid to read about this stuff, to go out and to spread the word, to do education around this stuff. And that's exactly what you're doing. So spreading the word about these rights. It's the thing that's posted in the coffee room that says, hey, and by the way, I should say, you're in a state that does protect, under its state law, people who are transgender. And that's great. And there's not that many states that are doing it. So we're pretty cutting edge. And then Massachusetts jumped right on our coattails and did it right after, about 2 years ago.
I'm sort of wondering, is there any attempt to change the language? Because it seems like from the first presentation, there was this succession to the language being less about it being an individual disability, which has a negative connotation to it, just the word disability, so to it being a collaboration between the environment and the individual in terms of the success for the individual and the success for society, because that person is being taken care of and that person contributes to their society. So the problem that I'm having is when we go to the Americans with Disabilities, we're using that word disabilities, and that's when we're getting into, classifying somebody who's obese as something's wrong with you if you have a disability. So it's different when you're talking about emotional and psychological disabilities than if you're talking about having a broken leg. That doesn't have the same negative
Well, and I think a lot of it does have to do with how you identify, self-identify. You talk about obesity. In my research, there was a nurse who sent in her resume for a position, had phone interviews, everything was great. The last phase was come in and, as soon as they saw her, she was obese. That was it. She didn't get the job. And she had all the qualifications to do this job. So that person self-identified as having a disability because it was clear to her that it was her weight that lost the job for her.
And she would get some advantages by calling herself under a certain language. And I can see now, which I didn't know before coming in here today, that all came from the medical profession to begin with, this whole idea of things being disabilities. But I wonder if there's any attempt to change the language. And your comment about the law being sort of backward-looking kind of answers that.
What you find is, there's a UN, and I'm going to screw it up, declaration on disability rights that does talks in terms of this social model of disability, but yet uses its anchor is impairment. It anchors it in the world of science. It's something tangible, because that's what a court needs to sink its teeth into. What is this? Are you just a lousy misanthrope, or do you in fact have X condition or something like that? Because I'm not going to protect you if you're this, and I will. They need that anchor of impairment. But what the UN Declaration does, but has all this nice language about, but really disability, guys, is not about his molecular structure. It's about what you put on that, your attitudes, your architectural barriers. Buses should have kneeled from day one, and they didn't because you forgot, this sort of thing. Your neglect of people with impairments. The ADA has some great language, and the ADA Amendments Act has even better language, but still uses that anchor of impairment. I think it's because it's more of a legal tool. Once you set that free, well, here's a terrific example. The ADA Restoration Act, the way it began, as a negotiation posture, learn with negotiation. I'm trying to sell a house right now. You shoot high, and then because you got to come down. We went with any person a definition of disability is any impairment, period. There it is. So we just made it the same. We didn't so we kept the medical impairment language in, and essentially what happened is business community comes back and says, oh no, there's got to be some kind of, it's got to be an impairment that substantially limits and so forth. There were some ways we worked around it. So now the ADA has carved a clear path that if you are treated unfairly based on an impairment, but we still have that in there. To go along with what you were talking about, this idea of there's impairments and then there's impairments. The ones that are stigmatized and then like the one that goes away. So the EEOC came in, the agency, after getting this new ADA Amendments Act. And the EEOC, and you can Google it, they laundry list a bunch of impairments and basically say these, for all intents and purposes, are disabilities. And literally from A to whatever, but I think, they're all in there. So anxiety, autism, and so forth. But I guess I don't have a great answer for how we change. Here's one. Let me put the question back to you. If we started protecting transgender people, if we protect the neurodiverse, people who we may not consider disabled under law, does that change things?
And bisexuality.
If we protected them under disability, that ought to change things. Yeah. And you know what? Where that's going is ENDA. So that's what they're hanging their hats on. The reason is, under the DSM, in 1973, they removed homosexuality from the DSM. They have not removed GID. Many people, transgender people, would not want them to remove GID because then they can't get a transgender. Is there there are still folks out there, there's a term for this, gay people who don't want to be gay anymore. And it's like this really small group, and I think there's kind of a religious connection in there, and they get bashed left and right from various blogs, and people can feel different ways on it. So I guess there is kind of that little, but nevertheless, DSM doesn't recognize it. DSM does not say. So isn't that, I guess where we come back to is you got the medical community still calling the shots, and the law is based on that anchor.
Just sort of along what you were saying with the terminology and disabilities, and when you were talking, Kevin, about the UN classifications, if you look at what they're talking about, and they're looking at activity limitations and participation limitations, it doesn't matter if you're transgender or you have a spinal cord injury, if you're having some impact on your activity and your participation in society, it seems like it should all be encompassed. And so if they use terminology like that, it would be more inclusive.
Yeah, and where the rubber hits the road is here with compromise, like you see in DC, business community and other folks will just not buy. I mean, they flip out. Yeah.
All right, well, thank you. Well, join me in thanking what turned out to be